I appreciate you taking a few minutes just to listen to talk. I'm happy to answer questions as we go. If you have a question, feel free to raise your hand. I'll leave time at the end for Q&A as well. So it's a kind of a wide range in the talk. So if there's any points you want to pause and just say, hey, I have a burning question I want to bring up now, feel free to raise your hand, and that's fine. So I work at the Florida Recovery Center. I'm the director there. I've been in addiction treatment for a long time, over 20 years. And I come through it from the therapy side of it. I'm not a physician, so I definitely will lean more in this talk toward the therapeutic side and things that I've seen through the years in working with patients and families. There's obviously, at the Florida Recovery Center, we do a lot of work with people and have neuropsychologists that do testing on people's brains and make sure that we treat a lot of healthcare professionals from around the country, doctors and nurses that come in. So a big part of what we do is make sure that they're safe to return to practice, right? And that involves actually doing neurocognitive testing on their brains to ensure that they're functioning properly to go back to whatever practice they're doing in medicine. And then we obviously treat a lot of people that are living their life and for whatever reason need help to get sober, right? Most people come to treatment. Most people, in my experience, come to treatment because something forces them into it, right? The reality is that, in theory, it's a nice idea that somebody wakes up in the morning and says, I want to change and stop drinking so much. But in actuality, usually it's their partner saying they're going to leave, they get fired from their job, there's a legal thing, there's something that presses a person to that decision. And so a big part of treatment is helping people shift from external focus to, hopefully, as they kind of move into actual recovery, to more internal focus and rewards. And so that's always something to keep in mind when, for example, in a room like this, I'm sure there's people that have experience in this, both maybe personally or also family members that they've tried to help through the years. And it is very difficult sometimes to kind of know that boundary of how hard do you push, when do you sort of put the brakes on yourself, take a step back for your own health. We'll talk about that some today also. But we have a lot going on at the Florida Recovery Center. As you can imagine, it's a hopping place. We have about 78 people living there today. So you can imagine the energy that can take place in a campus where you have 78 people that are on any level of continuum on trying to get sober. Some people are like, you know what, I don't think I'm doing this sober thing. And some people are really serious. So you kind of are always juggling those things on a campus. Let me start. I'll kind of start with understand addiction. This is a very generic picture of what we would think of with addiction. Someone's drinking too much. I'm going to run through some of these. Obviously, another thing you deal with. So, alcohol is still number one. It's number one on the hit list for what brings people to treatment. And we laugh all the time. It's like people say, I don't have a problem with alcohol. It's like, you do, you just may not know it yet, right? So alcohol also partners with a lot of things. In other words, if a person comes in because they're using too much cocaine, they shouldn't go drink alcohol, right, when they leave. There's a high risk that they could drift into that as well. So alcohol is always a partner in the mix. And usually one of the things we talk about is that someone will say, I don't have a problem with drinking. And you say, well, tell me about the last 3 times you drank. And they'll say, well, I drank only 3 times in the last 3 months, but every time I blacked out. And I have no idea what happened, right? So it's those kind of stories. And again, we'll get into some of the reasons for that. But addiction, when you're struggling with addiction, your brain will adapt to whatever substance that you offer it. Obviously, we deal with a lot of nicotine dependence. That's an interesting one. I could do a whole presentation on vape cigarettes and what that's done. Technology, right? We're seeing this. Anybody in this room right now, I have 2 teenagers. Technology is a real thing. It is stimulating. Social media, it's a big one, right? And for myself, I'm trying to figure out, what do you do about this? How do you monitor it? How do you control it? Even in our campus space, what role does that play in people's sobriety? Younger people, there's some real benefits to technology in the world of recovery. There's some real dangers there as well, also, with ways you can get drugs, and also the connections you can make with people. There's some unhealthy connections you can make also. And then, this is a big one. It's jokey with Tinder, but just relational connection, right? So one thing that folks can struggle with a lot in early recovery is drifting toward unhealthy romantic relationships because they feel good. So they always, when you start getting sober, the things that feel really good initially when you feel crappy are sex, food, and exercise, right? Those are things that are very stimulating. And so you have to be really careful in early recovery, and we work with patients of not drifting too much in any of those spaces, right? Where you get really obsessed with things, because your brain is looking for something to feel good, quick, right? To feel that fulfillment. And therapy is a thing you do that doesn't always feel good quick, right? It's an investment. It doesn't always feel great to work through issues in your life. And I can talk a little bit about some of the assignments we do in a little bit as we move through. And I mentioned the food piece. It's a big one for folks. Okay. All right, so let's talk a little bit about trigger and craving. These are two big features of addiction. We talk a lot about what is a trigger. So triggers are sort of anything, the visual, physical, sound, smell, memory, or just uncomfortable emotions that really start to bring up the craving, right? They kind of prompt it. It's the smell. So for example, our senses, we do this too. You smell a really delicious meal and it causes a craving, right, to eat that food. Even sight-wise, think about advertisements, how stimulating that is to our brains. Imagine that, but it's alcohol. Imagine that if it's crack cocaine, methamphetamines, any number of things. And I think in particular, I think there's pleasurable things. There's also very uncomfortable things. So we talk a lot in treatment about high-risk situations. A high-risk situation sometimes is negative, right? You walk into a room and somebody's using drugs. But also a high-risk situation could just be anytime you're emotionally vulnerable, which could be triggering. So for example, there's stories through the years of somebody relapses if they have a really intense emotional therapy session, right? Or they go to a 12-step meeting and somebody has a really vulnerable share. I remember years ago I worked with a guy and he had been sober for 30 years and he got his 30-year chip and he got drunk that night, right? So there is a triggering effect, and some of this is just you begin to get stimulated emotionally, and then where you go is you start thinking about using, right? And so we'll talk about, like, therapy is a lot of work. If anybody's been in therapy, and this is one of the reasons, like cognitive behavioral therapy, which is the most famous therapy for addiction, which is like helping people to slow down and really start to think about the connection between a trigger and then an action, right? And how do you start to slow that down and process what you're doing before just doing it, And that sounds kind of simplistic, but if you think about that as people, that's what we do all the time. And if you add to the fact, if you have a person in treatment that maybe started using drugs when they're 12, 13 years old, where that part of their brain's developing, it's very challenging, right? If anybody's interacted with a teenager lately, it's very challenging to help them slow down emotionally just to relax and just not make an impulsive decision. And so with that's a lot of things in treatment, is like identifying triggers, but then starting to talk through what actually happens when these triggers pop up, and how do you just not fall to pieces and just kind of go right to the impulse and fall right into where the craving happens, and I'm just a prisoner to it. And this is very difficult because people will talk in cravings. Cravings will not last long, but when they are there, they feel insurmountable, right? And we've all had cravings for certain things. It feels overwhelming. If you withstand that and start to develop some of those that impulse control, you can start to work through it. And this is why you need people to talk to and different things, as we'll talk about what recovery looks like. This is just the definition of addiction. I don't need to. You can look through it. I don't know if these slides will be available, but addiction is characterized by the inability to consistently abstain, impairment of behavioral control, craving, diminished recognition of significant problems. That's a big deal. You can't recognize it. With one's behaviors, interpersonal relationships, and a dysfunctional emotional response. Like other chronic diseases, addiction often involves cycles of relapse and remission. Without treatment or engagement in recovery activities, addiction is progressive and can result in disability or premature death. This is a very important feature of the acceptance. So this can happen with somebody you think about the stages of change. Anybody see that there's like pre-contemplation, contemplation, and you start to move through, then you're like, I know I need to change, and then I actually take action, and then I have maintenance on that change. With addiction, it's interesting. So this will happen, for example, with this thing, is you'll get somebody that comes into detox, right? They come into detox, and they're like, it's going real bad, right? Their family pulls up, wheels them out, they get them in there, and they're ready to go. I'm going to go to treatment, I'm going to get better, I'm going to do this. And then 2 days later, they're like, I don't want to go to treatment anymore. I'm going to go home now. I'm going to go back to work, right? And you try to explain to them, like, no, you need help, blah, blah, blah. And they're like, no, you don't understand. I'm going to go back home, and I'm going to be a dad or a mom. I'm going to go to my job. And they'll usually, people that have been through it a couple times will throw in I'm going to go to an AA meeting, right? That's like the trump card. It's like, I'll say an AA meeting, and then no one can say anything. So this is really interesting. It's not only do you start to recognize you have a problem, but you start to accept that you need help. That it isn't as simple as just saying, like, I'm just going to stop, right? So that is one of the challenges of working with folks in early recovery and in general is helping them not just accept they have a problem and they need help, but that they need to sort of continue down that road even when they don't feel like it anymore, right? So there's vulnerability in treatment. When a person first comes to treatment, they can be very vulnerable and they'll say, you know what, I'm ready to go. Also, when a person gets ready to leave, right, they talk about overconfidence, like, I got it now. I did this treatment, I did everything, I don't need to worry about it anymore, right? And so a big part of treatment is of just a drop in the bucket. That's like the starting point. What you got to move into and the real change of your life can be really challenging. This is one of the reasons that we at FRC, for example, like we let people go home on home passes, right? We want them to have a little taste outside of life, and life outside. Some people actually commute from home. They live at home and come to the campus. So you can start to get a little of those interactions with the stresses of life before you're not in treatment, which is an extremely safe place, right? Treatment's a very safe environment. We take care of you. You're in this room. We drug screen you all the time. If you need help, you have a therapist right there to talk to. If you don't show up somewhere, we come find you, right? We're like, where are you? That's not real life, you know? So treatment is a short span, but it's designed to help people get initial help, but also, and equally important, recognizing they need to continue getting help, or else they're going to fall back into the old habits. And then this is a big one. This is kind of a simple way, is you just continue to engage in behavior despite negative consequences. Some people call that insanity. This is just the history of addiction and substance use. It wasn't until 1956 that this addiction was even recognized as a disease. So there's a lot, this is a whole nother talk. But the long debate between, is it a disease or is it a moral issue? There's a lot of discussion about it. I think with the disease model, if people have been through, they're like, screw you, it's a disease. Like, you're pissed, you stole my money. Like, good for you that you have a disease that caused you to like take from me and hurt me. And people compare it to diabetes or hypertension. Obviously, the big difference is that if somebody has high blood pressure, it doesn't mean they might get behind the wheel of a car and like something tragic happens, right? So there's a real personality aspect in the disease model, and sometimes people throw that around, and it isn't always, it's used as sort of an excuse. I think there is a piece of like the disease of like, it's treatable, right? There is conditions we know that it is a disease, but part of the acceptance of disease is that you have to continue to do things in a maintenance zone. In other words, for people that have severe alcohol use disorder, there's not a time where their disease will be healed that they can go drink again, right? That's a really hard thing to accept, because people are like, so you're telling me I'm confused. Can I have a drink again? When can I have a drink again? It's like, never, right? And I don't mean that to be mean, and I'm not gonna it's not to be judgmental, but it's like you have the disease of alcoholism, part of the acceptance is that you can't just return there one day. And that can be very hard to accept. You also can't go smoke a bunch of marijuana, right? So it's very difficult. So the disease been 56, and then the AMA recognizes that all drug addiction is a disease. So that was 87 where they expanded that out, which think about that, it wasn't that long ago. And then in 2016, actually the specialist of addiction medicine was recognized. So addiction medicine is a pretty new field of medicine. There's been a lot of developments that there's now fellowships you can do. There's been a much more training on actually the world of addiction medicine. At FRC, we actually have addiction fellows that come in and do a year training with us. A lot of those folks are working in hospitals or family medicine. Also may go open up like addiction outpatient clinics, things like that. So this is just a little history. This is just talking about the brain, and particularly the prefrontal cortex, which we can talk about. So the big thing is and I'm not going to spend. I'm not a brain scientist, but the idea of the prefrontal cortex is that that's like that emotional, that emotions, actions, all that the cognitive functioning in that region gets really impacted by addiction. Not surprising, right? So decision making, the weighing of risk versus reward, assigning emotional attachment to stimuli, and suppressing your impulses, and then goal-directed behavior. So this is when people are using drugs, it's particularly if they're younger when they start, this part of their brain gets really impacted, and even when they're sober, they still struggle in decision making. They're still struggling to weigh out risk and reward. They overreact to emotional stimuli. They have very poor impulse control. They struggle with goal direction. So in treatment, this is a big thing early on, is like when you think about it in practice. So if it didn't affect your brain, you have a treatment center, everyone would come in, it would be the most wonderful place in the world. It'd be a bunch of sober people working on themselves, and you never have any problems. Spoiler alert, we have a lot of problems at FRC, right, with behaviors. So there's a lot of behavioral issues, right? People still struggle with impulse control. They still don't know how to deal with their emotions very well. They become emotionally dysregulated. Like something bad happens and you pack all your clothes and leave treatment impulsively. You don't know how to work through basic conflict with your roommate. Just little things that's what the treatment is, right? It's like, all right, good, you're not using drugs, that's great. Now we got to do work. Because your brain's still not working the way it should. And there is a real piece of this, though, you can see, is that the age of onset can really impact this. And certainly, we have younger people in treatment. They struggle more with impulsivity. But listen, we've had some people, we've had physicians in treatment that, when they're sober, function at a very low level when it comes to just decision making, not making impulsive decisions. These are some unbelievably intelligent people, right? So sometimes this can happen where early on people are like, I'm smart. Like, don't you get it? I'm smart. It's like, I get it, but you don't, your emotional management skills are terrible. When you have a session with your partner, you can't handle when you get upset and get hurt. You fall to pieces, right? And then you have to start connecting that back to like, what do you do with those emotions? And of course, for most people, it links into like all different sort of distorted thinking patterns, which is where something like cognitive behavioral therapy comes in, where you start to target that. It's a lot of work, right? This is where you start to get spirally. But this is just some of the stuff that happens with your brain. And then who needs treatment? This is an interesting slide. So 10% of society meets the criteria for substance use disorder. So the DSM-5, it defines, we'll go through the checklist. There's a checklist. It's not like, you don't shoot from the hip on this. Some people are like, I don't have a problem. It's like, well. And then approximately 2 million people aged 12 or older in 2018 had substance use disorder in the past year. And then this is a really interesting, only 10% of people who need treatment actually get treatment. So that's an unbelievably low percentage. You think about that number. We deal with this a lot. There's a lot of reasons for that, right? Sometimes people don't want to come to treatment, right? Sometimes people don't have the means to come to treatment. We still struggle as a society in knowing how to treat people with mental health and substance use issues. There's a lot of stigma around it. I'm not sitting here advocating that everybody should get free treatment that needs it, but there is sometimes people that really want help and they can't get it. Right? So there's a lot of reasons for it, but the reality is a lot of people go untreated for their substance use disorder. And this is kind of what the criteria of an actual alcohol use disorder might be, right? So you can see here, man, this is a long, you can see here, these are things you want to look at. I'm not going to read every one of them, but are they going to have these slides available, or I don't know. Yeah, okay. Yeah, so this is a good thing to look at. This is the criteria of like what it would look like in the past month, right? And some of these are really interesting. And this is the thing, right? So 2 or more symptoms in the past 12 months indicate a substance use disorder. A mild substance use disorder, right? 2 to 3 symptoms. Moderate, 4 to 5 symptoms. Severe, 6 or more. Now, I want to be clear, there's different treatment recommendations based on severity. I do think that's true, and we see that sometimes. I mean, you do have people that are at the beginning of this process, and I think there are people in the world that have moments of realization and get help. They go to a meeting, they go to a therapist, and they figure it out, and they don't go and develop into like full-blown, maybe their severities not to the extent that we see with some folks. But you can see that there are a lot of things to look at here when it comes to like what actually indicates someone has a substance use disorder, and there's tiers for it. So that's something to think about as well. And sometimes people think like, maybe I have a substance use disorder. It doesn't mean, sometimes I think if you think that, you probably don't. But the idea is to sort of, we actually do assess people, make a determination on why this is a diagnosis, and explain that to them. Now, whether a person accepts, if you look back at this, sometimes people's opinion on what these things are is different than what reality is, right? So if I say to you, have there been any times when you ended up drinking more or longer than you intended? Like, tell me about that. They'd be like, oh, no. And then if you talk to someone's partner, they might go, oh, yeah. We went to a wedding last week, and like I said, please only drink 2 drinks, and they promised me. And then they were blackout drunk, and in the middle of the dance floor taking their shirt off. It was horrible, right? So this is an interesting disease as well, is because sometimes you do have to get collateral, right? So this is why we have family involvement in treatment, because we want to know. We ask families to write impact letters sometimes to people, which is very painful to tell someone like, this is how your disease has impacted me, right? So this is a big thing. And as people, the nice thing, and this is interesting, with the first assignment people do in treatment is actually something called powerless. And what we want people to do is actually go through each part of their life and identify how their addiction has impacted that part of their life and how they've been out of control. Powerful, right? So an assignment like that directly targets, you need to start accepting you have a use disorder that's severe or whatever, mild or moderate, whatever you want to say, but you need to start looking at that, and the way to do that is to start being honest. Start being honest with the impact it's had in your life on all aspects, right? Because people also say like, oh, everything was fine at home, or my work was fine. And you're like, no, it wasn't. It wasn't fine. And if you think it was fine, you're just in denial. And we're not trying to be mean to you, but it's an honest conversation. Like, are you sure it was fine at home? Like your kids were scared, or your teenage son doesn't talk to you right now. Are we okay? Are we okay? Like this, so that being really honest about those things, which is so painful, because if you think about it, denial is such a big part of your addiction. And when you're using, you can't be honest, because if you did, you would just decompensate, right? If you really accepted, like, oh my God, I'm doing this thing and killing myself, you would just, and you're not getting help, it would cause your brain to just literally collapse on itself. So, okay, here's some substances: amphetamines, cocaine, Adderall. This is stimulants. These are things that are considered stimulants, and these are things that obviously speed up your nervous system and energize you, right? Methamphetamine, cocaine, Adderall, which is a big one. We get a lot of people that say, I have ADHD. I've been taking Adderall for 20 years, right? And we'll do testing to see if they actually have ADHD. That's a hard one for people. Caffeine, nicotine. Gosh, there's so many little rabbit trails we can go down here. We'll keep moving. Sedatives, alcohol, benzo, that's Xanax, Klonopin. Those are things. We've seen, that's a hard, so 2 interesting drugs, really hard for people to get off. So alcohol and benzos are the 2 substances that people need to be hospitalized for and detox before just coming to treatment, because they could die during the withdrawal. They could have seizures and die. So those would be the ones that we actually will keep people hospitalized if they're detoxing. The benzo is interesting. So alcohol you stop using, right? We don't taper you, but a benzo you have to taper people often off of the substance. So they say they're taking Xanax, you'd step them down over a period of time to safely do it. This is a hard one for people to let go of at the end. You can imagine you're on a very low dose and people are freaking out. Like, I don't want to let go, right? It's an interesting one. And we've had some people that have been taking a benzo for 25 years, right? And it's really scary. And then at the end of treatment, they'll be like, I never thought I would be off this substance. Ketamine, which is an interesting one in the world right now, because there is some research coming out that ketamine can really help with depression. There's actually a ketamine clinic at UF. And it's interesting research. The folks we work with, we're not going to recommend they go to a ketamine clinic, right? But I do think there seems to be some use for substances. And that's hard too, is that we know there's some use for some of these things safely and in a healthy way. People with substance use disorder history shouldn't go that route, right? It's not appropriate. And if you're keeping that a secret from a physician, that would be a problem too. This is opiates. These are the famous ones in the news, right? We have heroin, fentanyl, oxycodone, Percocet, Dilaudid, morphine. I mean, these are kratom, which is a really dangerous substance that you can actually get at gas stations. There's substances, we see that more and more. If you ever go to a service station, you might notice some of them have like a glass container and little closet-y looking, like clear closet kind of thing that has a lot of substances in there that are very dangerous, that are technically legal. You could just buy them. This is a whole nother world we deal with, and the whole other piece of treatment is you're drug testing people, and we've had a number of people that kratom has been a hard one for them, and they can just get it. You can just buy it. I don't know if you can buy it off Amazon, but you may. It's very easy to purchase, and it's not super expensive, and it's very dangerous and hard to stop using. Hallucinogens. Hallucinogens have also been something that have come up in the world of people using that in clinics as well. What can that do for you? Marijuana, LSD, mushrooms, DXM. Marijuana, interesting enough, is an hallucinogen. It's not a depressant. There's a lot of energy. Do I have one here? There's a lot of energy about medical marijuana, legalization of marijuana. We don't think, I don't think you should call marijuana medicine. I don't think that's a real thing. Whether or not you legalize it or not is another discussion, but we don't let people, like someone that, here's my medical marijuana card. It's like, that's not something you can do here, right? So, and it's not, again, you have to have some standards in treatment, where we had a young guy last year, and he was eating these little marijuana gummies, and he's like, I'm just gonna eat these and stay in treatment. It's like, here's the thing. We want to help you, but if you're going to not stop using marijuana, we can't help you. And it's no judgment. Like, then maybe you just need to go live your life, and we'll figure it out, and we're here for you when you're ready, but we can't co-sign you using marijuana while you're here, right? And that's something that you have to have in treatment, because if people are actively using, then no treatment's effective. Their brains aren't ready, right? If you're high, I mean, that sounds really simple to say, but when you're working with people that are using, it is something that they have to accept. Like, you can't have, your brain has to be like clear as it can be without a substance. Inhalants, this has been a huge one. This has been a nightmare. Inhalants are very dangerous, very easily accessible, and you can't test for them. We've had more inhalant use in the past year with folks, and again, across the board demographically, it hasn't been isolated to one demographic. We've had a lot of inhalant use. Really hard one to control and monitor, and really dangerous and scary. Steroid abuse, it's an interesting one, particularly for men. Steroids. Also abusing testosterone. That's a whole nother. These are all little rabbit trails we go down, where these can be really, really hard ones to deal with, that are harder to test for too. Addiction doesn't discriminate. Alcohol is the number one reason people seek treatment, for sure. That's our number one, always. Just because it's prescribed doesn't mean it can't be abused. That's a big one. Oh, it's prescribed by my doctor. Well, okay. Medical marijuana. I don't think it's that tricky. I'm just kidding. I think it's tricky. And it is, yes, it could be a whole nother presentation. Suicide risk are higher with those struggling with addiction. Not surprising there. Okay, impact on family. This is good. Okay, yeah, we'll run through these and have some questions. So we work with families. We have a family work. We're actually supposed to have a family workshop tomorrow. We're not going to have it because the storm's coming. But work with family is so important for people in treatment. Sometimes people come to treatment, they're very open to let their family be a part of it. Sometimes they don't want their family a part of it, right? And, there's varying reasons for that. Sometimes they say this person can be a part, this person can't be a part of it. We respect we can't just call anybody we want, obviously, when someone's in treatment. There's, in very important way, there's a lot of confidentiality and safety. But we would want to educate family as much as possible. We have family therapy sessions. We want people to come to family workshop, because one of the things we're trying to help family understand is, like, what's your role in this, right? It's not your fault. It's not blaming, but how do you sort of account for your own emotional state as this person's getting better? And how do you do things healthy? And there's words like enabling and codependency that get thrown a lot, or maybe people have heard those terms before. And they can kind of get thrown over every situation like a blanket. But really, you want people to start to think about themselves and what are they doing as they support their loved one, and how do they sort of take care of themselves, and so they don't inadvertently not even hurt the person, but kind of acts as a barrier in the recovery process, not as a bridge for that. The first stage is confusion and loss. As addiction begins to spiral out of control, the family follows a predictable pattern. Erosion of trust, control and avoidance, reactivity, communication breakdown, and over-monitoring. That can be a big one. So usually when people have come to us, there's any number of things that have happened, but certainly there's been a lot of erosion of trust in the family system. And so, when someone arrives for help and treatment, a lot of times they've lost a lot of relationships in their life, but the people that tend to be there are family, right? Parents, partners, siblings. But there's been a ton of erosion of trust. And so in treatment, you're helping a person understand that trust takes a long time to rebuild. That just because you decided to get better doesn't mean everybody needs to jump on the bandwagon and act like the past never happened. With families, you're trying to help people understand that it's okay to take your time, and it's okay to have expectations and have clear conversations. And this communication breakdown is you're just trying to get people to start having honest communication again. and really talk, because there can be dynamics set up and when someone's using, has an alcohol or addiction problem, is that nobody talks about anything, right? It's all avoided, because there can be this idea that if I don't want to upset this person, because then they might use and it'll be my fault. Or there's a lot of hyper control and there's a lot of like aggression and people are trying to like really control the whole situation. And so in treatment, that we have a patient, but then we have a family. And one of the things we want to do is encourage people to really kind of look at some of these deeper issues that have, not just issues, but the trust factor especially has been kind of broken down because of all the addiction problems. Fear and isolation. This is the care camp. That's what I was talking about versus the control camp. I've ever heard the idea of tough love. That's a really famous thing. Again, you can throw around words, but understanding what they mean in your context is really important. I think tough love is a good thing. I also think you have to look at what does this look like, depending on the situation. I think sometimes, particularly we've seen this with children, there can be splits, right? That two parental figures could be on either side of the spectrum, right? One tends to be more maybe enabling, the other person tends to be more like, they need to figure it out, right? A little bit more like moralizing. Even sometimes in relationships, you might have a partner or spouse, and then on one side, and your parents might be on the other side, right? And what's happened is those two people are in conflict, and meanwhile, you're using. So how do you kind of like stop the polarity and get everyone on the same page and start to understand that communication with the people that are helping is really important. And the person understanding not to split those people, which is challenging. Distancing, shame and blame, breakdown in family rituals, and family roles emerge and change how your family functions. The breakdown of family rituals is a big one to think about. I remember there was a guy, he was with us. This is a great example of like, he was sharing his powerless, and his family, he had a family ritual. They were going this vacation every year, and one year he forgot his drugs. And he was obsessed during the whole trip trying to get drugs, and he missed the whole trip with his kids and his wife, right? There was a family ritual that's just broken down. But holidays tend to be really ritualistic time for families. They can be really impacted by people that struggle with addiction, right? The distancing camp, you have the camp of people that want to bring the person in, the person that wants to distance them. But yeah, there's a lot of impact there. And in treatment, we really challenge people to look at the shame they feel about that, right? How do they really not just run from that shame, but really start to process it? And not just blame people, right? Oh, it's my problem, or my so-and-so was being a jerk, and take that ownership. And then also, what needs to change in the family system? And, some families make decisions not to have alcohol at events. It just depends, right? Everybody's different. But this fear and isolation, there's a lot of fear. And sometimes appropriately, there is isolation and distancing. Family roles. Okay, let's talk a little about the family roles. Just going to run through this. The family hero is like the superstar of the family. How much time am I going to spend on these? The scapegoat, the rebel, that's the person that gets blamed for everything, right? Lost child, that's the person that's sort of missing and just gets forgotten about, right? They tend to be a high achiever, and they're kind of out there on their own and are missing. The clown, right? The jokester, the person that's kind of like performing for everybody, and the enabler and caretaker. So there's a lot of mixture of family roles. We have a whole presentation we do at the family workshop, and when you start to dissect your own family, these roles show up no matter how healthy or unhealthy a family is. I think that's really important to understand. It's like we do this, right? When I look at my own family, I see things jump out, right? My brother or my sister or my mom and dad, and we just do. We tend to fall in these things. Addiction will tend to push these things to their most unhealthy states. Can really be the case. And depending on where you're at in this role, sometimes your addiction might get taken, might be dealt with differently, right? So if the rebel child or the scapegoat is kind of struggling with addiction, it might be a much more out there, talked about, almost like people are frustrated and angry. The hero is falling in that role. It might go underwater for a long time, right? So good example, if you have a physician that's a primary caregiver or a financial provider in their home, their addiction might go unchecked for a long time because they're a hero to the family even, right? They went to medical school, they did X, Y, and Z. So sometimes people that have more status and have that hero status, it can take longer for things to really be accounted for. And if people are like lost child, they disappear, That can be the person in the family that's just kind of underground. People don't know what's going on. They're kind of going under the surface. So you'd be interested as you kind of look at the patients look at their roles as well. All right, stage 3 is hopelessness. This is usually before the person comes into treatment. People just kind of don't know what to do anymore. And we'll get calls like that where the person's like, I don't know what to do. We had a woman, this is a very sad story. This was a little bit ago, but she was in treatment. Her family was just hopeless, and it was sad. And she had a relapse after she left and got a DUI, and her mom called just hopeless, right? I don't know what to do, right? And there's not easy answers to those questions. You kind of have to help support the person, really encourage them themselves to look at things. But also, I think the big thing for families is I don't think you should ever give up on the person. But you got to rethink what your boundaries are and how you're going to offer help. Adversarial relationships, there can be a lot of depression. You're living on the edge. Everyone's very hyper vigilant, it's exhausted. The families just become very splintered, so it's kind of in name only. And the family roles become traps, right? They become sort of the identity, and the people kind of really retreat into those roles. And then obviously this can be a place where people, there's be some real mental health issues, right? Anxiety, depression, people get in really unhealthy spaces because this addiction is really impacting every part of the family system. Okay, signs for concern. All right, I'm going to stop in a minute and do some questions. Sorry, there's a lot here. Signs for concerns, patterns of behavior. So let's say you're concerned, you're wondering I don't know, maybe I'm seeing some changes in so-and-so. Is there a problem with the substance use? By the way, really hard conversation to have. I don't care who you are. If anybody's ever done that, to have a real conversation with someone you love about whether or not they have a substance use problem and might need help is probably the hardest thing you'll ever do. We work with people, we've tried to work even with physicians of we're therapists, and it's hard to have that conversation sometimes with people, let alone if it's someone you love. Patterns of behavior, acting out, change in personality is a big one. You just notice people are different. Mood, mental health issues kind of start to pop up. Lots of excuses, needing people's help constantly, and facts don't add up. Early on, sometimes people will recognize the person used to act this way and now they act this way, right? So a common thing families will say in treatment is I want my loved one back to the person they were before, right? Because there's real changes that happen. And then sometimes that person comes back, it looks a little different, but that's usually the thing. The person used to get straight A's in school, and then all of a sudden they start failing classes, right? They were the best employee, they got Employee of the Year, and now they stopped showing up for work and got fired. There becomes really big changes that can affect things. They used to be really kind of caring, and now they're mean. It's just that kind of stuff. And honestly, part of it is you just start to notice you'll start to, if you look deeper, you'll start to see there's some substance use trickling in here. And if you look deeper is usually when you start finding some things that will back that up. And it's interesting because there's so much shame around substance use. It's pretty common for people to start hide it from their family, right? They'll hide it in the garage. They'll hide, they'll have a whole secret life. But usually, when the person starts to own that, the family goes, "We knew. We just didn't want to say anything. We didn't know how to talk about it." Now what? These are things, the do's and don'ts, right? Stay calm, have a plan, stick to it. That's a big one. I think boundaries are a really big thing, but actually having a plan and sticking to it is really important, and having boundaries for what that looks like. It doesn't mean you don't keep helping a person. It just means you have some parameters by which you're going to do that. Focus on behaviors, have support with other loved ones, keep people staying on the same page and you getting your own support, and then expecting denial. So one thing for people is you should expect it doesn't mean, we talk in treatment about a lapse versus a relapse. You don't want people to relapse and use again, but you want people to be prepared if they do slip, what they'll do about it. Right? So the pattern so much with people is if I use, then I just sort of give up hope and go back, I'm all the way back in. Versus I slip, but I have things in my life that can help protect me. Same thing for family. You might have days where you feel really discouraged, feel hopeless. Do you have support in your life to talk about those things? Or are you kind of out on your own as well? Because that can be a dark place to be. Set boundaries, we talked about that. Don't look the other way when there's things happening. That's important. Don't ignore that. I think we do talk a lot in treatment with people is that with families, like, are you comfortable saying something if you have concerns, right? You should be. Because what will happen is, say a person, you get a call from so-and-so's, husband, the person left treatment, they say, oh man, she got home and it was going really well, and now she's in her room all the time, she's not coming out, like what do I do, right? And how do you and we'll say, well, you should talk to her and see what's up, right? What's going on? It's like, I don't know, I don't want to upset her. So really working on how do you just have honest conversations. But also, you shouldn't be the only person supporting. You shouldn't ever try to intervene alone and expect a confession. I don't know what that one means totally. I don't know why I put that one. That's all right. Give up. Don't give up. And don't personalize the issues. That's really hard to do. If anybody's ever been through that, that's almost impossible. Because we're like, it is personal. Okay, 3 C's. You did not cause it, you cannot control it, and you cannot cure it. That's a big one. Making sure you accept your limitations. And then awareness, the A is awareness, acceptance, and action. These are from Al-Anon. Anybody heard of Al-Anon before? Okay, Al-Anon's a really big support group for families dealing with folks with addiction. Really good. They have their own 12 steps. The theory is as a person, you actually have to go through your own recovery and healing as well. In expectations in early recovery, it's important to be cautiously optimistic about the disease of addiction. This can be hard. I think you want to enter this space, whether you're getting sober or you're the person supporting someone getting sober, is like, you want to be optimistic, but you should be guarded in that, right? It's one of the cognitive distortions that people struggle with in early recovery is all or nothing thinking, extreme thinking, right? It's all this or all that, right? And the reality is most of it's gray. You should be optimistic about staying sober, but also aware that it could fall to pieces, right? That you're vulnerable. Same thing for families. Like, it's good to say, like, there should be some measures of like, you know what, I'm glad you're sober, you did that treatment, but maybe it's not the best idea to go over to John's house tonight and hang out and watch him drink beer, right? Let's be real about it, right? I'm not ready to trust you that much to just take my car and bring it back. Whatever it is, it's okay to have boundaries, and the person needs to be able to handle that. They need to be able to understand and have empathy for your position. Recovery is possible with help. Relapse does happen. Don't panic. That's a big one. How do you not panic? How do you work through that well? And as a growth opportunity versus like, oh my gosh, we're back to square one. And again, so much has to do with the support someone has in their life, and do they have people that speak into their life? Because families have to realize that the goal, there's a worksheet we do, I like to do, it's like a CBT worksheet. One of the questions is like, who do you have to talk to if X, Y, and Z has happened today? And I tell people, don't put any family in that slot. Don't put your family in there. Doesn't mean you should never talk to your family, but you got to have people that know what you're talking about and can challenge you and aren't just going to buy into your BS, right? Aren't just going to or freak out. So it's like the person you call if you have cravings is not your mom. Doesn't mean your mom doesn't love you. If I want to have a drink, I'm not calling my mom. She's going to freak out. Like, it's too much. She's already scared to death. That's where you got to talk to people that are in recovery. They go, it's normal. We get it. Like, I can relate to you. So, widening that, moving outside of that isolation space, because the family to be isolated with that person is a real recipe for disaster. And people that know addiction and are in recovery themselves oftentimes, or just know addiction, have worked in it a long time, won't freak out when somebody slips or thinks about using. It's expected. And that's really important. And again, there's a place for family. It's really important, but they can't be the primary recovery support necessarily. And in some cases, people have family members that are in recovery. I think that's great. Those sometimes will be family members that can be more supportive. And things take time. This is a long process. These are some resources. All right, I ran through really fast at the end. Okay. These are some good things to think about. A website called SAMHSA. SAMHSA's great. I don't know if anybody's ever been to an A or Al-Anon meeting. They have open meetings if people want to go. Okay, cool. Oh, and we're built, so for those, I'll end with this, and I'll do some questions too. I know that was a lot. It was like a big information dump. Our current location is on the corner of 441 and Williston, heading out of town by Meridian. It's funny, it was a converted nightclub as our clinic, and our resident where the patients live is actually a hotel. So the irony, of course, is like that wasn't always a place where people were pursuing recovery, most likely. So we are actually moving, though. We're building a new campus. We're going to be moving behind the psychiatric hospital over on 39th Avenue, right off the interstate, the health park by Spring Hill, across from the ED. So we're building a whole new campus, and there's reasons for it. One, the campus we're at is kind of falling to pieces. It was like, a brick fell out down. Maybe we should move. But also, we just need more space. We're growing. We have more and more patients that need help. We're trying to figure out more diverse ways to get people into treatment as well. There's a real need for that. There doesn't seem to be, no matter how much marijuana is legalized or how much people act like it doesn't matter or drugs are okay, it just seems like more and more people need help. So there's a piece of that. Like, you can make marijuana as medical as you want. There's still people that need help. We're growing, and that's kind of, I think about another year from now, we'll probably be moving over. So I'll stop there. I know that was a lot of info. Questions, things people want to ask, feedback. Yes, ma'am.
Is your program all on a volunteer basis? In other words, the person has to agree?
Yes. So this is a great question. Yes, the answer is yes for the most part. We do have people sometimes that get a Marchman Act. So there's a couple things. All these are like rabbit trails you could just have a whole talk on. So in the state of Florida, you have people have probably heard of a Baker Act. Baker Act, of course, is like something that happens when a person's in psychiatric distress and they are involuntarily sometimes admitted to a psychiatric hospital for a deeper sort of assessment, and then sometimes that Baker Act extended where they actually will involuntarily. There's something called a Marchman Act. Marchman Acts are for substance use. So say so and so is really impaired. The police come. They might get Marchman Acted. There are times where we're a Marchman Act receiving facility. So sometimes a person will be admitted to treatment against their will because the danger is so high that they would die if they're not in treatment. Like they might overdose or they were drinking so much that they need a new liver. Things like that. But that's a very small percent. Most of our people, yes, are there voluntarily.
And then when you say it's difficult for some people financially and so forth, how does that work in the program? How is a patient's fees paid for?
Yeah, so self-payer insurance, we're working to get with Medicare. Medicaid's trickier with just reimbursement. The state of Florida is not the best state when it comes to indigent care. Meridian does some more stuff. I think that's something we're always trying to figure out is how to get more people treatment that don't have the resources. We work with people primarily if they have healthcare insurance or self-pay options. And then trying to develop scholarship stuff, that's a whole other challenge if people want to give back. But yeah, it's a real hard thing in Florida. There's some better resources now that people can utilize. So let's say someone calls and needs that, we can refer them to certain places to get help as well. But yeah, it's hard.
You do have a variety of different levels.
We do. Yeah, so we have inpatient, we have the PHP with housing, which is 7 days a week. We have IOP, which is in the evenings, and we actually have outpatient too, where someone just sees a psychiatrist. The goal is to step people down, obviously, but to your question, not everybody has the resources or frankly the time to do that, right? So there is a piece of you're meeting people where they're at, you're trying to figure out the best plan for them in their life circumstances. Oftentimes there's an ideal plan. The reality is most people don't have 3 months sometimes, but we want to at least get them as close as possible and get as much as possible and then have a good aftercare plan for them to leave, which is really important. Yes, ma'am.
So how do you handle people who've gone through the 3 months, they're doing good, and then you see them going?
Right.
They're not quite there, but
right.
You see them going. What can you do?
Yeah.
You have a former.
Yeah, so you intervene, right? You do pretty intense intervention with the person and their family if you're really concerned. Sometimes people do use in our campus. So I think it's hard in treatment to balance like the challenge and not let it drift into shame and really encourage the person to be honest. Sorry, so you would just bring it to their attention. You would, part of treatment from a therapeutic standpoint is building the rapport. The person will hopefully trust you. And I think it's less about if, it's probably when. What are the things as a person's transitioning that are popping back up that are their personality or their struggles that if they don't check it could take them back to kind of where they came from. So one of the things we do a lot of work on therapeutically is helping people identify what their personality is, and then what parts of their personality are things they need to be mindful of, right? So anybody ever did work like we do some work in the Enneagram space, which is an interesting personality kind of profile that really targets what's healthy functioning for you versus unhealthy. I think the big thing you want to see for people at the end is, are they open and willing to hear the feedback of like they're struggling, or people are seeing things they can't see in their blind spots? Can they hear that? A lot of people can. And then you have people that can't, and you work as hard as you can to bring that to their attention. And sometimes people listen, sometimes they don't. It usually is just a common place at the end of treatment. It's like you have very specific groups and things that people are working on related to that as well. Like,
What do they do? Can they call you?
they can, yeah, for sure. So let's say it's a great question. Let's say, for example, I leave to FRC and I start drinking that day, which could happen. We do have people that will come right back in, or we talk to them, and like sometimes it's not about them coming back to treatment. They might need to just engage with their plan. They might need to just like might have a conversation with them on the phone or their family and remind, like, this was the plan, let's get back and stick to it. It just depends on the person. But we're available if people need to call and talk through that, for sure. It's hard though. That first stretch when you get out of treatment is really hard. It's really hard, no matter how much you prepare for it. Because yeah, it just is. It's just difficult. And the first couple of years of recovery can be very difficult for people. It can be really painful. Yes?
You simply have to go into detox at first?
Yeah, so what we do with that is everyone needs to be assessed. So we don't just take your word for it, but so, people say certain things. So everyone goes and gets assessed at our hospital. And if they're oftentimes they're cleared to come over to us. Sometimes people need to be entered in there medically. But we assess everybody medically before just letting them come over. Because sometimes people are drinking or using more than they let on.
All right, we got one more over here.
Thank you for taking the question. I was just trying to see, when you said control and over control, what are the benchmarks that we have to look for? Say, supposing somebody is controlling you while you're detoxing or you're getting off the habit. Now, all of a sudden, what is the benchmark that you look at? That they are over controlling or they are not over controlling? What is
For their use, you mean?
Yeah, but about controlling the person who is recovering.
Oh, you mean say that for them coming to treatment or for them having an addiction problem?
So if they have an addiction problem, and then they go ahead and go for the treatment, and they are recovering.
Right.
So the family role or whoever is controlling you from
Right.
when you come to the family sessions, what are the benchmarks to look at to see that the person who you are controlling?
Yeah, that's
stepping over the bounds or not?
like when do you kind of let go of some of that control? How do you know? Oh my gosh, that's a good question. I don't know. I'm trying to think of a way to quantify that. I mean, I do think some of it is just you're going to make some choices for yourself, regardless of the person's behavior. If that makes sense? So you're, as a caregiver, going to take a step back and evaluate the whole situation, right? And some of that is conversation and expectation. So if like we're having the conversation, we're just going to start talking. I'm sober now, and we can have a real conversation about what's the expectations of our relationship moving forward. And for you should be thinking about like, what am I willing to do and not do in this relationship? Where am I going to extend myself? And what are my expectations for whoever it is on the other side? I think it's a lot of conversation is what I would say. And I think it's unsure. Sometimes you make mistakes, right? Sometimes you think this works well and maybe it doesn't. That's like it's a hard question to answer definitively. I would just say the features I've seen are people that really start to reestablish or develop healthy communication patterns, where then there can be an exchange of like, how's it going, right? It's like, is it too much? Is it too little? Like what you're kind of reassessing. It's kind of like any of us, like if you've been in a healthy like like partnership in your life of any sort, you are assessing and seeing how you're checking in on the relationship. I think with addiction kind of like removes the check-ins, right? It's like the person's, and it becomes all about that person. I think when the person's getting sober, there is a re-engagement on that process. So it's just a lot of conversation and figuring that out and accepting that sometimes there'll be some mistakes, but if the person's healthy and in recovery, you can work through those things, right? There's going to be margin to work through it. I don't know if that helps. It's hard. It's really hard.
We got time for one more question.
Yes, hi. I was wondering, in families that also drink, and
Yeah.
are particularly worse than the others, is there a plan or hope for those people?
Yeah, it's a really good question. So like I'm going home and my partner drinks excessively, or I live with my parents and they drink. My dad drinks every night. I don't want to make it gender specific, but I think that's a lot of conversation and treatment about what's controllable in that environment. Sometimes the person challenges their loved ones too. And again, you don't want to make it, I'm not going to take their inventory and say they need help, but I think the person in treatment, like, is that a safe place to live? I'm going to family functions where alcohol is prevalent. How do I handle that? So as you're kind of assessing a person's family situation, that becomes part of the conversation with them in treatment. And then how much does the person on the other side of the equation, how much should they be involved in this process and how much conversation happens therapeutically? And are there some cases you just have to accept the person, maybe you're not going to try to control that and you just have to be more mindful when you're there. Do you not go to family function for a little while? Do you not live with so-and-so because there's alcohol or it's unsafe from a substance use standpoint? And from the family side, do the people try to do too much to control that too? I don't know if that, like, it isn't always like the family's job to just make everything, like it's like a baby-proof the house, right? So that's the dilemma too, is you got to kind of have those conversations. Again, there's that communication, but I think we start with the patient. What is the landscape of your family? And part of that is who's using in your family and you want to go to the family reunion next weekend, what's happening there? Are you okay if everyone's drunk? How are you going to manage that? Should you go with an AA like a sponsor from AA? Should you not go? Should you leave and go to a meeting? There's all those conversations you have to have. But it's a big question in treatment, particularly with the people that you're living with. We have college students from UF get treatment, and they're going to commute from their apartment, and their roommates smoke weed. Right? We have to have a conversation. Like you're in college. Like you can't hang out with everybody and tell everybody like, I'm here, nobody do anything, right? You got to figure that out. So you're kind of really balancing and working with people about it. It's a hard question though. Because sometimes people want their expectations that nobody should do anything around me. I'm like, and other people are like, do whatever you want, I'm fine. It's like, well, no, I don't know. It's not that simple.
I'm going to invite my friend, Callie up here, quick, just tell a little bit about the Florida Recovery Center.
Thank you. Good morning. Thank you all for coming. I appreciate it. It's great to see faces, and I'm sure the storm did affect that. But I wanted to introduce myself. I'm Callie Wilkes, and I am helping to get support for the new building. The Florida Recovery Center new building is not fully funded, so I know some of you may have experience either personally or, like Dave was saying, your family. And if you have gratitude and you want to express that in some way, please come introduce yourself to me. I'd be happy to talk to you at another time. But yeah, it's really important, and we're happy to have you here. Dave, thank you for your talk. But I'd love to meet you if you're interested in learning more about the building and how you can help us.
Yeah, we take cash too. All forms of payment. No. Also, we were, just as a little thing, because I feel good about this, we were ranked #1 in the state of Florida for treatment the last 2 years, and then #5 in the nation for treatment. Whatever the algorithm is, it worked out in our favor. We were the #1. That's great. We were one of two. No, I'm joking. We're #1, so that's great. We're #1. All right, I think that's it.